Good evening and welcome to what month are we in? March? The March edition of the Doctors Hospital Distinguished Lecture Series. We are happy to be joined tonight by our Weight Loss Solutions program team talking about obesity in the Bahamas. So I'm going to quickly introduce our speakers and we'll dive right into tonight's live lecture. So first up is Dr. Jan Martin. Her professional education and training include a doctorate in advanced studies in human behavior, which has prepared her to teach, consult, and lead mental health, physical health, and wellness programs across the lifespan. A Master of Science degree in counseling studies with a clinical counselor concentration helps create strategies with treatment teams and patients to achieve personal health and wellness goals. In addition, advanced studies and diplomas in medical nutrition therapy, diabetes education, obesity management, health and wellness coaching, and personal training for special populations equip Jan to support children and adults during the behavior change process. Next up, we will be joined by Dr. Ariane Davis-Simmons. Dr. Davis-Simmons was born in Freeport, Grand Bahama. She's a part of a medical family with her older sisters practicing pediatric dentistry and pulmonary critical care, respectively. After completion of high school in Freeport, Dr. Davis-Simmons attended the University of Maryland and graduated in 2004 with a Bachelor of Science in Biology. She pursued medical training at the University of the West Indies in Trinidad and completed her clinical training at the Nassau campus, graduating in 2010. She worked briefly at the Princess Margaret Hospital as a senior house officer and later pursued specialty training in internal medicine at the University of Maryland, Baltimore. After graduating and completing a chief resident position in 2016, she began subspecialty training in endocrinology, diabetes, and metabolism at MedStar Union Memorial Hospital, graduating in June of 2019. Her interest in diabetes and endocrinology began early in her medical training, spurred by the diagnosis of diabetes in her father and type 1 diabetes in her 9-year-old niece. She initially watched them struggle in different ways with their diagnoses and management and knew that if she understood this field, that she could make it easier for them and others to successfully maintain their health despite very real challenges. Her expertise includes and is not limited to diabetes management, diabetes technology, insulin pumps, and continuous glucose monitors, thyroid disorders, thyroid ultrasound, and thyroid biopsy, medical obesity management, pituitary, parathyroid, and adrenal disorders. Growing up in the Bahamas and having her formative medical training there has had a significant impact on her. After completion of a rigorous fellowship program, she was eager to return to the Bahamas to use her skills to serve the population that inspired her to pursue a career in endocrinology. And then finally, we will be hearing from Dr. Ranga, who is our consultant surgeon here at Doctors Hospital Health System. He has a diploma in laparoscopic surgery. That always gets me. He's a fellow of the American College of Surgeons. He's also a fellow of the Royal College of Physicians and Surgeons in Glasgow, United Kingdom. He has a diploma in robotic surgery from the University of Lorraine in Nancy, France. And he's also had many fellowships in bariatric surgery in both at the Whittington Hospital in London, UK. With over 25 years of general surgery experience, 20 years of laparoscopy experience, and 10 years of bariatric surgery experience, Dr. Ranga is well equipped to talk about all things related to bariatric surgery. So those are our three specialists who will be speaking tonight in our distinguished lecture series. So we'll begin with Dr. Jan Martin, and we are talking again on the topic of obesity in the Bahamas. And as always, we will open the floor for questions at the end for our audience if you have any questions for our panelists. So let's get ready to hear from Dr. Martin.
Where the slides? Where the slides? Good evening. This evening, my colleagues and I are going to address the topic of obesity. This topic is extremely important because we have the prevalence of obesity continues to grow worldwide and in the Bahamas. So we will cover the prevalence of obesity, the physiological status of obesity, health risks and treatment, obesity, lifestyle, behavior modification, nutrition, fitness, stress management, and of course, treatment that includes bariatric surgery and pharmacotherapy. We will close with questions, so hold your questions until the end. So what is obesity? Obesity has been labeled as a medical condition. It is described as excess body weight in the form of fat in the body. When accumulated, this fat can lead to severe health impairments. The prevalence of obesity across the world continues to rise in the Bahamas as well. Next slide, please. The prevalence of obesity in the world, according to the World Health Organization, we have 2 billion adults who are currently overweight, and 650 million of those 200 billion adults, 650 million are obese. Now, obese meaning according to the body mass index, and the body mass index of 30 and above places someone in the category of obesity, and it goes up in increments of 5. Now, overweight is someone with a body mass index of 25 to 29.9, and obesity starts at 30. The World Atlas results from 2022, published by the World Obesity Federation, predicts that 1 billion people globally, including 1 in 5 women and 1 in 7 men, will be living with obesity in 2030. And we can see just by looking around us on a daily basis, especially here in the Bahamas, how obesity has grown over the last 5 to even 10 years. It is expected that 1 in 4 of us living in the Bahamas and throughout the world will be living with obesity by the year 2035. In addition to that, we have childhood obesity expected to increase by 100% between 2020 and 2035. And as I said earlier, with adults obesity, we can actually see our children becoming obese just by looking, if we go around to the schools, if we go to little kids' parties, we see the little plump children running around. And so these statistics were cited from 2020, and it is predicted that by 2035, we will have an increase of 100%. The greatest number of people living with obesity are in the low and middle income countries, and we also see that. In the Bahamas, the prevalence of obesity continues to rise, as I said earlier, and we have over 70% of our adults who are either overweight or obese. If you would remember, in 2014, the Bahamas was ranked sixth in the world as the most obese country. And Bahamian women account for 50% of obesity. And this graph shows that we have 80% of our women who are either overweight and obese, and 55%. And this graph is from 2019. So we're in 2024. And so we can see that these numbers continue to rise. And if we were to do studies now, these numbers would be really higher than they are now. This other graph here shows the amount of adults living with obesity in the Bahamas. And this graph is from 1988 to 2019. And at that time, we had 40% of our adult population in the Bahamas who were obese. Like I said, we're in 2024 now. And so if we were to do a census on overweight and obese adults in the Bahamas, the number would be way over 40%. And this graph here shows the prevalence of obesity among children. And this was done in 2013 by a study done by the Living Survey. And it showed the increase in overweight and obesity among our children. And if you notice that the girls, the females, are leading the pack from childhood into adulthood. And so why is obesity important and why are we addressing it? We're addressing it because of the prevalence, not only worldwide, but in this country. Obesity has now been defined as a disease. It is a chronic relapsing disease, and it fits into the epidemiological model of a disease process. A disease process is influenced by a microbe. However, with obesity, the pathological agent is diet related. And so I'm going to bring my colleague, Dr. Davis-Simmons, on to talk more about what obesity is, the physiological factors involved in obesity, the treatment involved in obesity as it relates to pharmacology. And then after she's done, she will bring on Dr. Ranga, our bariatric surgery, to speak about the surgical, non-surgical, and surgical options of treating this chronic relapsing disease. And I will return with the behavior modification that is necessary and that ties in with the pharmacological treatment and the bariatric treatment.
All right, so we will be joined shortly, as Dr. Martin indicated, by Dr. Ariane Davis-Simmons, who is. We will be joined shortly by Dr. Ariane Davis-Simmons, as indicated by Dr. Jan Martin, who will continue our conversation on what is obesity. As I indicated earlier, Dr. Davis-Simmons is an endocrinologist who works here at Doctors Hospital Health System. She has been with us for, I think, going on 4 or 5 years now. Since she returned to the Bahamas to practice, she has been working with us, and she works out of our Centerville Medical Center location, located on Collins Avenue. So if anyone, and we'll drop all of this information at the end as well, but if anyone is interested in visiting with anyone, any member of our Weight Loss Solutions team, you're welcome to give a call to the Centerville Medical Center office to set up an appointment. So we will be continuing our presentation now with Dr. Ariane Davis-Simmons.
Next slide, yeah. So there are many factors that lead to obesity. So classically, we used to think obesogenic environment, meaning high caloric foods and having a genetic susceptibility, meaning my family is big boned. However, obesity is a lot more complicated. It's really complex. So obesogenic environment can include a lot of things, meaning stress, so financial stress, emotional stress. Is there sleep deprivation? So if you're not sleeping effectively, cortisol levels are going to be higher. It's going to be very difficult to lose weight. Having a sedentary job, excessive screen time, being exposed to endocrine disruptors can also lead to obesity. When we think about genetic susceptibility, that even extends from your time in the womb. So what we call epigenetics. So exposure factors when you were carried in your mother's uterus. So if your mother was obese, if your mother had diabetes, you are at increased risk of developing obesity later down the road. Medications can promote obesity. Classic medications will include insulin, sulfonylureas like dimicron, antipsychotic medications, menopausal status. So we see a lot of women gaining weight in the menopausal transition. Post-pregnancy, weight retention, so difficulty throwing off that weight post-pregnancy. Next slide. So there are many comorbidities associated with obesity. So as Dr. Martin said, obesity is excess fat. And this has affects multiple organs from your head to your toe. So it increases your risk of pulmonary disease, obstructive sleep apnea. For women, they may have, more commonly in women, they may have idiopathic intracranial hypertension, so they may get headaches. It can lead to fatty liver, so that excess fat becomes stored in the organs, in the liver. Increased risk of gallstones. Women may have gynecological abnormalities, so abnormal menses, increased risk of PCOS, infertility issues, urinary incontinence. As we know, we always think about metabolic complications associated with obesity. This would include diabetes, hyperlipidemia, so high cholesterol, high blood pressure. Obesity and excess fat can lead to increased risk of solid cancers, such as breast cancer, uterine cancer, cervical cancer, pancreatic cancer, kidney and prostate. So it does affect multiple levels in the body. Next slide. Good. So how does obesity cause disease? So it can be, one, through the excess fat burden. So the sheer weight of having the excess weight can lead to biomechanical effects, meaning knee arthritis, obstructive sleep apnea, increased risk of GERD or acid reflux, urinary incontinence. Also, the excess fat acts as an endocrine gland. So it releases excess hormone, it releases prothrombotic effects, inflammatory effects. This can lead to blood pressure elevation, insulin resistance, and abnormal blood vessel growth. So we know that even modest weight loss, if you're overweight or obese, can have some benefit. So if you have prediabetes or abnormal blood sugars, losing just 3% of your body weight can lead to improvement of blood sugars. 5% weight loss can lead to improvement of blood pressure. 10% weight loss, if you have sleep apnea, can lead to improvement of sleep apnea, and it can lead to improvement of your NASH score. So that's fatty liver scores can improve. If you have type 2 diabetes, 15 to 20% excess weight loss can lead to remission of diabetes. Next slide. So when we talk about weight loss and what drives us to eat, the process of appetite regulation is very complicated. So there are environmental cues that signal for us to eat. So that's using our senses, the smell. And then we have centers in the brain called your hypothalamus, where we have a food reward sensor. We have an appetite and sensory processing. And all of this is a gentle balance. So we have, when we do eat and have a meal, we have gut hormones that go up and they signal to the brain to say, hey, I'm full. So you have satiety hormones such as GLP-1, and you also have hunger hormones such as ghrelin that make you feel hungry. So it is very much a delicate balance between your brain, your stomach and gut hormones, and your fat cells, which also release hormone to control how much we eat. And we are pre-programmed with these cues. And this is why it can be sometimes a challenge when people go on a diet, because they have all of these hormonal drivers that do drive them to eat. Next slide. So we know that the body has a weight settling point. So the body tries to defend the highest fat mass. So when you gain weight, the body actually wants to maintain that weight. And it does have maladaptive mechanisms in order to prevent you from losing weight. Next slide. So there's lots of adaptations to weight loss. I don't know if you guys remember The Biggest Loser, that show where obese individuals went into an intense lifestyle program, diet, exercise, and that was for several weeks to months, and most of them lost tremendous amounts of weight. However, when they were followed in the months to years after, all of them had weight regain. And why does that happen? That happens because the body, again, wants to defend the higher weight, the higher fat mass. So as you lose weight, your resting energy expenditure starts to go down. So what your body needs just to function, for the organs to function, all of that goes down, and the hunger hormones start to go up. So those hormones such as ghrelin, go up, so you start to feel hungry. The satiety hormones that make you feel full, such as GLP-1, leptin, PYY, CCK, start to go down. And this what drives hunger when you start that diet. So I think a lot of us experience that when we start a intense diet program, we're able to stick with it for 2-3 weeks, and then we kind of fall off the wagon. And that is not due to laziness and not being dedicated. It's because your body has these maladaptive mechanisms. So when we think about obesity management, there are pillars to obesity management. The cornerstone is going to be lifestyle management, which includes diet, physical activity, and behavioral modification, which Dr. Martin is going to elaborate on later. And for certain individuals, we then can add on obesity medications if they are not meeting targets. And for certain individuals who meet criteria, you can also consider bariatric surgery. Next slide. So when we think about pharmacological management of obesity or obesity medications, they are indicated as an add-on to a lifestyle modification, meaning as an add-on to a energy deficient diet, increased physical activity, and behavioral modification. So obesity medications based on NIH criteria are for patients who have a BMI of 27 or more with a weight-related complication. So for example, diabetes, or for those who have a BMI of 30 or more with no comorbidities. Next slide. So another consideration when you are evaluated for weight gain or obesity management is to look at what are the current meds that you're taking. There are a lot of meds that we are on that promote weight gain, such as diabetes medications, insulin, sulfonylureas, antipsychotic medications can also promote weight gain, antidepressants, anticonvulsants, antihistamines. So even Benadryl on a chronic use can lead to steroids such as prednisone and glucocorticoids can also promote weight gain. So if you are on these medications and struggling with weight, it's worth to have a conversation with your physician to see if there's alternatives that you can be switched to that will have less impact on your weight or can promote weight loss. Next slide. So what is the rationale in adding medications on for obesity management? We know that obesity is a chronic relapsing medical condition, just like other chronic diseases such as diabetes, high blood pressure, high cholesterol, and these have to be chronically managed. Next slide. Next. We know that the biochemistry of people with obesity is not the same of that with lean people. And just if you have struggled with obesity and you lose weight, your biochemistry does not automatically become the same as a lean person. Because remember, we talked about that adipose set point and the maladaptive mechanisms that you have in your body that's trying to promote weight regain. Adding on some of the obesity medications help to change that biochemistry. They help to change the hormones, meaning increasing the satiety hormones, suppressing hunger hormones. So the addition of a medication to a comprehensive weight loss program adds an additional benefit to help reach your goals. So these are a list of the FDA-approved medications for obesity management. There's phentermine, topramate extended release, orlistat, naltrexone, bupropion, liraglutide, 3.0 milligrams, which is Saxenda, semaglutide 2.4, which is Wegovy, and tirzepatide high dose, which is Zepbound. So when we choose obesity medication as an obesity provider, we look at several factors. We look at what medications are maybe contraindicated, which ones are not, which ones have dual benefit. So if you have diabetes and obesity, we'll consider medications that can also lower your blood sugar and help with weight loss. We take into consideration patient preferences, adverse events, prior experiences, and then obviously you have to be comfortable as a physician with these medications before prescribing. So when we look at weight loss medications, they are meant to be as lifelong therapy. So if we look at this study where in the yellow bar is the semaglutide, so that is low dose Ozempic, high dose Wegovy. As we see, there's tremendous weight loss in that first 20 weeks where people are losing up to 10% of their body weight. But after that 20 weeks, they're then switched to placebo. And as you see on that gray line, there's some weight regain. Those who stayed on the medication continued to weight loss. So I want to highlight that because as we know, these medications are pretty much TikTok famous, the Ozempic, the Mounjaro, all of these. And all they do is work by suppressing the appetite. So when we said they help to increase the satiety hormones, make you feel full, and that helps to suppress the hunger hormones. So if you do come off of them, it is expected that you will have weight regain. Next slide. This is a nice graph showing all of the FDA-approved medications. In the orange bars, that's the placebos. Those are patients who were put on placebo versus the medication. So as you see, all of the meds do have significant weight loss, anywhere between 6% to 10%. That's the older medications. That would be the liraglutide, the naltrexone, bupropion, the phentermine, topiramate. However, the newer agents, or we call the secondary phase medications, the newer kids on the block have more robust weight loss with the semaglutide, people losing about 15 to 16 or even 17.4% of their body weight. So rivaling kind of the standard of care with weight loss, which is bariatric surgery, where it's about 25% or more of weight loss. So there's a lot of new medications in the pipeline with tirzepatide being the newer agent. Click for me, please. Tirzepatide being the newer agent with the most robust weight loss, but there are other medications in the pipeline that work at the GLP and GIP targets, which help to improve satiety, feeling full, to add the benefit of weight loss. Next slide. Thank you.
All right, so thank you, Dr. Davis-Simmons, for that excellent segment of your presentation. And as indicated, we are going to now be joined by Dr. Ranga, who is going to talk about some of the bariatric options that exist for those who are looking to treat obesity and attempt to get their weight under control and go through the weight loss program. So we will now be joined by Dr. Ranga.
Yeah, hi, good evening. So I'm Dr. Ranga. I'm the surgeon and a part of the team here at Doctor's Hospital. So I come into the picture when our morbidly obese patients, when they join the weight loss program and they go through all the required guidelines that we follow with Dr. Martin, with Dr. Simmons. And then at some point of the treatment, I will meet with the patient and discuss the various treatment options regarding intervention, basically surgical interventions. So the basic intervention that we can offer the patient is the balloon, the intragastric balloon. So the indication, so it is good for patients who have a BMI of 30 to 34, or who have a BMI of 70 and above. So basically who are super obese or severe obesity, as we call them. So the balloon has a role in these two sets of patients. But by far, the most common that we see here is the BMI of 30 to 34. It's interesting because before the balloon came into the market, it's a pretty recent introduction. The FDA has approved only just the one company now that manufactures the balloon, called the Orbera balloon. The name of the company is Apollo Surgicals. Up until now, there was no intervention that we could offer for patients with the BMI of 30 to 34, because surgery is only indicated for patients with a BMI of 35 or above. So now the balloon sits nicely in that little space, so we can offer this to patients with a BMI of 30 and 34. So the balloon is, if you can see the image, that's the balloon that's sitting inside the stomach. It is introduced into the stomach through an regular upper GI endoscope. So we introduce the balloon inside, we inflate it and disconnect it and then leave it there for a maximum of 1 year. It cannot be there for more than 1 year. And then the weight loss starts to happen within that time. So basically what the balloon does is it is heavy and is a space occupying entity. So it gives the patient a feeling of fullness the whole time because of its presence in the stomach. And the brain is fooled, is tricked into thinking that the patient is full all the time. So it does not trigger any hunger or anything like that. So the patient will not feel like eating or drinking too much. So and because of that, they lose weight. So because we use it for patients between 30 and 34, the weight loss that is to be expected is in the range, it's a quite a wide range, between 30 and 60 pounds. But we very commonly see 40 pounds, very common to see patients losing 40 pounds. Some of them do well, they do 50, even 60 pounds. And very extremely rare situations where they actually go more than 60 pounds, like even 70 pounds, but that's not common. So now these are the surgical options. Just a little brief history on this bariatric. So the surgery has been around for weight loss for almost 50 years. So it's not a new concept. It was discovered by surgeons 50 years ago when they removed the entire stomach or part of the stomach for cancer, for other conditions. And they realized as a side effect, the patients were losing a lot of weight, and some of them who had the comorbid conditions like diabetes were getting nicely controlled without any drugs or anything like that. So then over the years, they started to play with that, experiment with that, with those procedures. And then recently, not recently, maybe 20, 25 years ago, the surgeons, we started to offer these specific procedures aimed specifically at weight loss. So that's how it's quite an interesting history, like many other conditions that we discovered by accident. So this is just one of those situations where it worked out well for us. So now, so over the years, there's been many surgeons describing many different kind of procedures with modifications over the years. Some had good results, some not. In some, the patients lost too much weight. The quality of life wasn't good. So over the years, recently at least, we have streamlined all this and sort of limited our surgical options to a handful of procedures, which work really well. So out of which, I'm just going to talk about the more common options rather than the more unusual or the rarer procedures. So the most common is this, what we call as a gastric sleeve, what patients call gastric sleeve. So the technical word for that is sleeve gastrectomy. So this is a good procedure. So this is the basic, most basic procedure for weight loss. And right now, it is the most commonly done bariatric procedure in the world, with almost 70% of surgeons for performing this particular procedure. And over the years, it's been tailored, it's been modified, it's been refined. We have many books have been written on it. Many conferences, many discussions have led to now the procedure being quite standardized. It's good because of these reasons. It's simple to do, relatively. The complications are less. The time taken to do the procedure is also quite less, about 2 hours, maybe less. The quality of life after the surgery is also superior compared to the other procedures. And of course, we do all of this through laparoscopy. So there's no more laparotomies or big incisions. So that's added there's cosmetic appeal to the patients also. So this procedure is good for patients who are looking for a weight loss of somewhere between 80 to 120 pounds. Again, this is just a general thing, sometimes maybe more, but they can expect to lose a minimum of 80 pounds. That much is guaranteed. The upper limit of weight loss, it may be 120, sometimes a little more than that. So the next procedure now is now called the mini gastric bypass. Yeah. So the mini gastric bypass is also again a relatively new procedure, which was first described by an American surgeon called Rosenthal. There was a lot of controversy behind this procedure, but now many centers in the world are doing this procedure. But sadly, in the US, it's banned. This procedure is not being done in the US. For there's a lot of other controversy. That's another story by itself. But many other surgeons around the world who have been doing, including myself, who have been doing this, we find this is a really good procedure. It's a good alternative to the actual Roux-en-Y bypass, which is the more common and older procedure, which is described. So this is a slightly more simpler procedure compared to the Roux-en-Y gastric bypass. I mean, technically, it's slightly easier to do. It takes less time. So the less time is beneficial for the patient because the patient has to be under anesthesia. So less anesthesia time is always better. And the weight loss is still good. It's still good between somewhere between 100 and 180 pounds. The patients can expect to lose weight. So when you compare this with the gastric sleeve, of course, each procedure has its own indications, we call them. Not all patients will require the same procedure. So when I assess them, I will do a lot of tests. I'll do ultrasound scan. I'll do an endoscopy. I'll ask them several questions about, especially if they have reflux. So depending on these problems, each patient, we will have a discussion with the team, and then we will decide which is the best procedure for that particular patient. So it's not just about the technicalities. There's a lot of other issues involved, and I make it a point that the patient is always actively involved in the decision making. So I explain to them very clearly about all the different procedures, the drawbacks, the benefits, and then I would tell them what I think is best for them. But I also will tell them that I need to hear from you. What is your opinion about all this? And so it's a joint kind of a decision. Next. So, and this is now the standard Roux-en-Y gastric bypass, which is the oldest bariatric procedure, in fact, that's been around, and it's effective. It's time tested. It's a good procedure. The only drawback here is it's technically demanding to do, takes more time, and because if you can see the slide, the image on the left is the normal anatomy of the stomach and the intestine. The image on the right is what it would look like after the procedure. So if you can see, there's a lot of cutting, there's a lot of joining, there's a lot of rearrangement of the anatomy to get the weight loss going. Definitely, it is a good procedure for weight loss. People can lose up to even 200 pounds weight loss with this. This procedure is really good for patients with a severe reflux problem, with a big hiatus hernia. This procedure is much better than the others. Now, the only drawback of this is because of the extensive rearrangement of anatomy, we can also expect more complications, both long-term and short-term. We see a lot. So that's why Roux-en-Y gastric bypass now is slowly, I think, beginning to lose favor now with the surgeons. Especially with the other gastric sleeve and the mini bypass, that's getting more popular now. So we reserve the Roux-en-Y gastric bypass only for a small handful of patients that really need it. So just a brief slide on why does bariatric surgery work so well? Why does it work so well? So basically, it depends on the procedure. So the gastric sleeve works in a different way, whereas the bypass works in a different way. So just to, I can't get too much into the technical aspects of it, but in layman's terms, so the gastric sleeve, basically, we call it a restrictive procedure, which means we are restricting the size of the stomach and also removing the portion of the stomach that secretes hunger hormones. So this way the patient will not feel hunger or feel very less hunger, number one. Number two, because of the size of the stomach is reduced drastically, there's a feeling of early satiety, which means you feel full very fast after eating or drinking just a small amount. So this way your intake is reduced, and over the months, the weight loss happens. The bypass and the other procedures, they are a combination of restriction and malabsorption. So because of the rearrangement of the anatomy that we do, there's malabsorption of the food that we eat. So most of the fat and other foods that makes you put on weight will get excreted undigested in the fecal matter. So thereby they lose weight. But the side effect of that, the drawback of this is your fat will also get malabsorbed, but at the same time, all your essential minerals and other like things like calcium and vitamins also get malabsorbed. So you lose that as well. So you'll need to replace that for many patients lifelong even. So those are the drawbacks of the malabsorptive procedures, which brings me back to why the sleeve is still such a good operation, because it balances well between malabsorption and weight loss and quality of life. Next.
Thank you, Dr. Ranga. And so now we will be rejoined by Dr. Jan Martin, who will finish off our presentation, talking about behavior modification as it pertains to weight loss solutions. And so we are pleased to wrap up our presentation this evening with Dr. Jan Martin.
Slide. I'm back, and I'm here to advise each and every one of us how to choose healthier food options, talk about the preparation of the foods, and of course, the portions. If you're obese and your desire is to lose the weight because you're obese or you have conditions, healthy food choices are extremely important. So Dr. Ranga just talked about the surgical options for obesity. The surgical options for obesity requires that persons adhere to a restrictive diet prior to surgery and a specific diet 10 days before surgery. A part of that is 10 days before surgery, patients go on a liquid diet to prepare the stomach for the surgical procedure. And I'm starting here only because Dr. Ranga just finished, and I wanted to keep that in mind. Before you see Dr. Ranga, you sit with me and we look at the foods that you're eating. We look at the types of foods you're choosing. The main food group that really needs to be addressed is your carbohydrates. Why? Because carbohydrates are the gas for the body. And there are different types of carbohydrates. There's the low glycemic carbohydrate, moderate, and high. So it's those high carbohydrates, those high glycemic, those starchy carbs, those sugary carbs, those crunchy potato chips we like at the end of the day. Also the drinks, the sodas, the juices, all of those foods we sit down and we talk about and we start to restrict them step by step. In addition, Dr. Davis-Simmons spoke about the pharmacological treatment for behavior changes and weight loss. Along with the pharmacological treatments, persons also need to be on a restrictive, healthy food choice type of meal plan. And that includes, as this slide is showing you, your fresh fruits, your vegetables. Whole fiber foods are very important. Why? Because as you eat those, they fill you up, and they fill you up for longer, and it does not affect your blood sugar levels, as does the starchy vegetables and the sweet drinks. Another area, food group that we look at is the type of oils that you're using to cook your foods with. And we recommend the monounsaturated fats or the polyunsaturated fats. And those are your, those are your extra virgin olive oil, your plant-based oils. We also look at the types of protein that you're taking in. Fish is extremely important. Fish, the oils in fish are monounsaturated, polyunsaturated fats, and fish is a good protein to supplement the red meat out of your diet, and so is chicken and turkey. Now, dried beans and peas, legumes, are high in fiber. They're also protein. And so for persons who want to go lean more to a vegan lifestyle while they're making these changes in their nutrition, we recommend increasing the beans and the peas and the legumes in your meals. The vegetables that we're looking at are those dark leafy greens. That's your lettuce, your cabbage, and we have different types of cabbage, and spinach. And of course, regular physical activity is extremely important. Now, the World Health Organization, the American Diabetes Association, recommend that we exercise 5 days a week, at least 30 minutes. For persons wanting to lose weight, the recommendation is 300 minutes per week, and that is 45 minutes to 1 hour. The results from making those changes, those healthy food changes, incorporating the whole grains, the beans, the fruits, and the fresh fruits and vegetables, will lead to weight loss. It will also lead to lowering your blood sugars, your blood pressure, and improved total cholesterol and triglyceride profile. It's going to lower your risk for developing chronic non-communicable diseases if you don't already have it in conjunction with obesity. Next slide, please. And so the improvement in your diet will lead not only to weight loss and reduce the risk of you becoming overly obese, it also provides essential vitamins and minerals. It decreases your risk and for you reaching out to include supplements. We only need supplements when we're not getting the vitamins and minerals from our daily meals. And so including the rich fruits and vegetables and legumes in our diets, we're getting those vitamins and minerals in abundance. Choosing a healthier lifestyle and healthier foods will boost our immune system and reduce our risk for catching the common cold and other bugs that are in the environment. It also supports healthy growth and development, especially in children who are overweight and obese. It helps with their bone health and their growth. It reduces, as I said earlier, chronic diseases, and it improves digestion. As Dr. Ranga mentioned and Dr. Davis-Simmons mentioned, we have some patients who come in and they complain of feeling indigestion sometimes, and most often the food changes. When we change to a high fiber diet, we decrease the indigestion, and so our digestion improves. Our mood and energy level increases. And also, choosing healthier food options reduces the risk of cancers. And so if we're looking for Next slide, please. If we're looking to lose weight, the American Diabetes Association and the World Health Organization recommends that we decrease our caloric intake by at least 500 calories per day. And for some persons with a body mass index higher than 50 or 60, we're looking to decrease it up to at least 700 calories per day. For surgery, as we're getting closer to surgery, we put persons on a very low calorie intake prior to them going to surgery. As it relates to exercise and fitness, what we've found is that the higher the body mass index of some persons, they have mechanical problems, as Dr. Davis-Simmons would have mentioned. And some of those mechanical problems prevent them from engaging in walking or any aerobic activity. Aerobic activity increases oxygen through the body. So instead of walking, I recommend they sit and do chair exercises or swimming. That takes its resistance training, so it takes the weight off of the joints. And as they lose the weight, then we can bring in some walking, maybe in the ocean or the pool exercises. Anaerobic exercises, they build power, strength, and muscle. We know from studies that muscle helps to burn fat. Increased muscle mass then takes the space of the fat tissue. And so I encourage persons to get 2-pound weights. Start with 2-pound weights or 3-pound weights. And for some persons, they cannot afford to purchase weights. I recommend that you get two bottles of water or some cans, or fill up empty bottles of water with sand, or lift some rocks in the yard, something that will give you the form and the strength that the weights would do to increase your muscle mass. It builds power, it builds strength, and the muscle helps to burn the fat. Agility training is another category of exercise that I encourage persons to do as well. Agility training is simply moving from side to side, bending, walking forward, stopping, starting again, as though you're on the tennis court and you're stopping and starting. You build muscle in that muscle group, and it helps to reduce the risk of injury for persons, for everyone, because it builds the lower body. So the aim for exercise, as I said earlier, is 5 days per week, starting with 30 minutes. That's only 150 minutes of moderate intensity aerobic exercise, 5 days a week. And I always add with patients, not missing 2 consecutive days. Why? Because on the 3rd day, your mind says to you, no, not today. And then the 4th day and the 5th day comes, and before you know it, a week has passed. And so if you keep the consistency up, the muscles begin to grow and you start to feel better. And that's when you get the changes. For weight loss, we want, as I said earlier, we want to increase our intensity. We want to increase the length of time that we exercise, still working 5 days a week, not missing 2 consecutive days, but we want to stretch it out from 30 minutes to 45 minutes. And then what I recommend to patients is every week or every 2 weeks, add 5 or 10 or 15 minutes. And before you know it, by the end of the month, you're up to 1 hour without stopping. Isn't that fabulous? Next slide, please. And the benefits of regular physical activity is not only weight loss, it's the mental health. You think more clearly, you're able to sleep, you're able to function better emotionally. You're not as sad, you're not as quick-tempered, you're able to step back and think rationally through issues that you're faced with, and deal with stresses in your life in a more calm, focused way. It also increases our social health. Why? Because you can ask a friend to go with you. You can bring your family out with you. You take the children out to soccer, well, mommy can walk around the track while the children are playing soccer. And of course, the physical health. Okay, it reduces your blood pressure, your blood sugar, your blood cholesterol. It builds your immune health. And of course, blood flow to the heart and brain. And it builds your bone density. I always like to talk about stress management with the behavior modification, because all of us on a daily basis are dealing with some stressor. Some of us are working in conditions where the stressors never seem to stop. They just pile on each day. If you're exercising regularly, you're able to assess the stressors and stop and slow down. I like to take a negative word and flip it to positive. And so we take stress and we flip it. We stop, we slow down. When you stop and slow down, you're able to breathe. When you breathe, you're allowing oxygen to go to the brain and you're able to think. And you can think more clearly about how to move, what to do, or maybe in sometimes what to say or not to say. Resources come. Sometimes that resource person is sitting right next to you in the office. Sometimes if you would have lost your keys in the house, you could retrack your steps if you stop, breathe. You're able to think your way through where you put them down in the first place when you walked into the house. So resources are always available, but we need to just stop and be still. And then we can think more clearly. Now, when those resources come, not everyone is a resource that is a good one, as I said earlier. So you want to evaluate them. And maybe you want to strategize and see which one you'll choose first, because you may have 3 or 4 resources and they may not come in the order in which you need to use as a solution. So you're able to strategize and bring in support systems, because it's the support systems that help you through your behavior change process. It's the group of friends that you have who say to you, oh, you're looking well, you lost weight, huh? You're tipping around the office and you put on something that you know you didn't fit in last month, and you get people noticing. Those are your support systems, and those are the people who will support you without inviting you out for a meal that they know is your trigger. And that brings us to behavior modification strategies. We all have triggers. We have triggers for stressors. We have triggers for any problem behavior. In this case, it's obesity. And in this case, we know what our triggers are as it relates to food. I know one of my triggers is chocolate. So whenever Dr. Ranga goes to London, he brings me back chocolate. I leave them in the office. So I only eat 1 or 2 while I'm in the office. I don't take them home, because I know if I take them home, I'm going to eat them. And so we all need to identify those triggers that send us to the grocery store to buy the things that we love the most, to soothe us for that moment. And then moments later, we are guilty. We're fussing ourselves for falling off the bandwagon. And so when we identify that, we also have to identify our feelings, our beliefs around our weight, our beliefs around food. You know, for us in the Bahamas, food is social. It is very social. Not only that, we're in the Easter, we're coming up on Easter, hot cross buns and fish and family events. So those are triggers for persons who are truly working on their weight issues. So bring in those support systems within the family. Let them know what you're doing and ask them to support you during the family events. Because our culture dictates that we have peas and rice, macaroni, potato salad, coleslaw, plantain, all on one plate with the fish and the chicken, and then afterwards, the desserts. And so if we're on a weight loss journey, that is a no-no for us. And I encourage patients, do not stop your social life because you're on this journey. Find support systems, know your triggers, know how food affects you. We eat with our eyes first, and then our sense of smell. And so if we know that, then we need to know how to avoid those triggers. Increase the planning, plan. That brings us right back to the stressors. When we plan, then we can evaluate that plan and see how that plan is going to fit in to our behaviors. And of course, always support systems. And that support system is extremely important. You don't want a support system from your past who engaged in the same behaviors that brought you to the point of obesity, and now you have an illness. So setting realistic goals for change are extremely important. And in the behavior modification arena, we look at setting realistic, smart goals because we're all smart, right? So they need to be specific. They need to be modifiable. They need to be measurable. They need to be actioned out by you, not me, your behavior therapist, by you. I will support you though. And they need to be realistic. If you have not been working out for years, then we need to start with a 15-minute slow walk every day. And then the following week, bring it up to 20 minutes. So realistic, smart goals is the key. And they also have to have a timeline. I am going to walk 4 days this week. And notice I said 4 because you have not been doing anything. So let's start with, I'm going to walk 3 or I'm going to walk 4 days this week for 15 minutes each day, not missing 2 consecutive days. And then next week, you bring it up. I'm going to walk 4 days or 5 days. And that is a realistic, smart goal that leads to behavior change. Remember, behavior change is a process. So by the time you get to see Dr. Davis-Simmons and reach, if you're going to have a bariatric procedure, you would have walked through the areas of behavior change. You would have thought through all the processes, the pros and the cons of losing weight or keeping the weight on. You would have identified your triggers. You would have identified the stresses in your life and identified the reasons why you need to change and lose weight. Next slide, please. And so what we are here to encourage you to do is to get started. Don't quit. Don't quit before you get started. Don't quit after listening to us this evening. Start talking about it. Start talking about beginning tomorrow or even later this evening. Just get up and walk outside and come back in. Do that several times and you would have completed 10 minutes, and then tomorrow you start again. Start with cutting back on the portions that you put on your plate. And there's an acronym that I love to give to persons, and if you have a pen handy, you can write it. It's called PIP. Plan your day. We plan what we're going to do every night before we wake up, before we go to bed. For women, we plan what we're going to wear to work. And for some men are becoming so savvy in their dress now, they plan what they're going to put on. We plan. So plan your strategy. Plan how you're going to start, when you're going to start. And the I is the ingredients. Ingredients in food. I just gave you some that you can start with. And also I like to use the ingredients with the people you keep in your life. That's your support systems. Are they health advancing, or do they take you back to your old habits? And the next P is preparation. How are you going to prepare the food? Are you going to bake, boil, broil, or grill it? with very little sauce? Or are you going to continue to fry it in the saturated fats and the oils and bread it? You think about that. And the last P is the portions. And I like to encourage persons to first think about the portions of love you give to yourself. Because when we love ourselves, we want the best for ourselves as we want the best for the people in our lives. So it starts with you today. It starts with you talking and beginning to do. So let's start to make the change today. Thank you very much, and we'll take questions.
All right, so as Dr. Martin indicated, we will now open the floor for questions. I think we have a few that are already sitting in our chat box. So what I will ask is for our other presenters to stand with Dr. Martin as we go through the questions that you'll be able to answer. All right, so the first question is a question referencing the measure of obesity. So this person wanted to know if there's any other measurements for obesity besides BMI. For example, from the standpoint of someone who's a bodybuilder, would BMI be, it wouldn't be accurate for them because their BMI would indicate they'd be obese. Dr. Martin, you can take that. Let's make sure we can hear.
There are measurements for obesity. There are measurements for obesity that are outside of the standard BMI. The BMI is standard because they have the World Health Organization had to come up with a number that would suit the many millions and billions of people. But yes, we do have persons who are bodybuilders. And so if they come into my office and they have a BMI of 35 or 40, I can look and see their body composition is mostly muscle. But we have a scale in the office that I use that measures the body mass index. It also measures the body fat percentage. Calipers also measures the amount of fat tissue on a person. And so if we have a bodybuilder and he or she has a body mass index of 35 or 40, we look at what that fat percentage is. And so those are the standards. We also look at measuring the waist to hip circumference. Now, women should have a waistline of 35 or below. Now that's the standard. There again, just from the eyes, we can look at the body composition and determine, but we always measure the waist. We measure the hips as well. Why? Because we need to know what that hip ratio is as well. But more importantly, that waist ratio is extremely important because the larger the waist, the more compromised you are for cardiovascular illnesses, metabolic syndrome, prediabetes, type 2 diabetes. And so those are the standards we use. For men, we want a waist circumference of 40 or below. And those are standard numbers again, but those are the numbers, the waist and the body fat composition will tell us whether the person is truly obese.
Okay, so another question we have is that a lot of people generally don't eat the daily recommended servings of fruits and vegetables. Why wouldn't that be a directive given to patients to eat more fruits and vegetables when they feel hungry, as opposed to being given medication?
Okay, as I said in my behavior modification, persons would come to me, and while they're working with me, they're working simultaneously with Dr. Davis-Simmons. And so if she writes a prescription for medication, she is expecting that the person is in the behavior modification program with the medical nutrition attached to the pharmacology. Now, the standard fruits and vegetables for adults, we're looking at 5 up to 9 servings, depending on the age of the adult. And those are the vegetables that I spoke about, the low glycemic the less carbohydrates, the less starchy vegetables. We're looking at the kales, the spinach, and we encourage half of the plate to have those vegetables. The next quarter of the plate are the starchier vegetables, and those we have in less proportion, less amounts than the low glycemic vegetables. So those are your potatoes. If you're going to have rice, it's a 1/3 cup. If you're going to have oats, if you're going to have grits, it's a 1/2 cup. And so, yes, we do encourage increase in fruits and vegetables. When it comes to fruits, we have to look at the types of fruits we encourage persons to eat, because there are many fresh fruits out there that are very high in sugar. For instance, bananas are extremely high in sugar. And so if the person is obese and they're also diagnosed with type 2 diabetes or prediabetes, I recommend that they reduce the amount of bananas or to eliminate bananas and choose a fruit that has a lower sugar content. Berries, watermelon, oranges, apples, they're higher in fiber and lower in sugar, because a carbohydrate is made up of fiber, sugar, and starch. And so we want the carbohydrates that are higher in fiber, lower in sugar, and lower in starch. And so for adults, we want about 2-3 servings of fruit a day. And a serving in the Bahamas, we need to understand that a serving is either a 1/3 cup, a 1/2 cup, or 1 cup. We tend to eat more than the serving. And that is why my PIP acronym ended with portions, portions of love and portions of food.
All right. So another question we have is, with the various surgical options, which obviously are intended to limit consumption, how does the body then get enough nutrition to function?
Yeah, that's an excellent question. I don't think I had the time to cover that part of it in the talk, but yeah. Now, first of all, you must know that the obese patient was already consuming too much to start with, which is why they became obese in the first place. So you don't need that much calories. You don't need that much intake in the first place, right? You must remember that. And after surgery, of course, Dr. Martin will follow up on all the patients and advise exactly what they should eat or drink. And that diet is calculated to cover all what the body needs. And as the weight loss is happening, the ongoing weight loss will again, the patient will end up needing less and less, because as the weight loss happens, you don't need that many calories like you needed before the operation. So it's crucial to follow up with the team even after the surgery for many months, just to avoid this particular thing, so that to avoid deficiencies in vitamin or calcium, or deficient even the calorie intake also. So you don't want the patient to lose too much weight too soon and be nutritionally deficient.
On another note, just to take off where Dr. Ranga left, once a patient has had surgery, before surgery, we teach them what to expect post-surgery and the types of meals to choose. And protein then becomes their best friend forever after surgery. Why protein? Because protein helps to build new cells in the body. Protein burns fat, and it keeps the patient satiated for longer periods. And not only that, we encourage them to choose the low glycemic vegetables, which are your dark leafy vegetables that are packed with your minerals and vitamins, so that you don't become deficient.
Okay. Someone asked, is the Weight Loss Solutions program covered by insurance?
Aspects of the program are covered by insurance. There's only one insurance company on the island that absolutely covers the bariatric surgery, and that's CG Atlantic Medical, and they follow the protocols from the Food and the FDA and standard protocols. The other parts of the weight loss program that are covered are Dr. Davis-Simmons's visits, Dr. Ranga's visits, and the nutritional consults are covered, especially if persons have a condition like high blood pressure, because we have to treat high blood pressure with a special meal plan called DASH, Dietary Approaches to Stop Hypertension. And then if they have type 2 diabetes, we treat that with a low carbohydrate meal plan, low caloric meal plan in all instances. So there are parts of the weight loss program that are covered by the insurance, definitely.
Okay. What are some risks involved with the gastric surgery options?
Right. So I wonder what they mean by risk the complications. I wonder if it is. I assume. Yeah. So like any other procedure, the gastric sleeve also has its own complications, but thankfully they are extremely rare. And we know, as we are trained surgeons in this field, we know how to recognize them if they happen, and we try to avoid them in the first place, of course. And if at all they do happen, we are trained to recognize them early, and we can tackle them. So the most common that we see complication is bleeding from the surgical site. That's one thing. And then the leak, we call it from the surgical site. The leak is one of the dreaded complications, but luckily it's very rare. It's like about 1 in 1,000. So because of, if you do the surgery properly using the proper instruments, techniques, and all that, the complications are very rare. But there are complications. That's the bottom line. Is nothing is complications free. Yeah.
Okay. Yeah. All right. Are we able? Sorry, someone asked if we're able to give an idea on the price range of the surgical options at Doctor's Hospital.
Price range. This is probably not a good setting to talk about the price range. Right. It varies depending on each person, what they need, what surgery they need. Okay. It'd be better if they inquire on the phone, or even better would be to come in person. Yeah, for those things. Yeah.
Mm-hmm. Someone else asked, is someone who is under NHI under Doctor's Hospital, are they able to access the weight loss program?
Unfortunately, NHI does not cover nutritional consults. If the person has type 2 diabetes, I have agreed with the doctors in the clinic to see the person with type 2 diabetes for an initial visit with no charge. But certainly the follow-up visit needs to be paid, and that is much less, the cost is less than the initial visit. And so for weight loss, no, NHI will not cover the weight loss nutritional consults, and neither will they cover Dr. Davis-Simmons consults or Dr. Ranga's consults. And it is unfortunate, and maybe the general public needs to reach out to the Ministry of Health to find out why, because we have over 70% of our population who are obese, particularly the women, over 50%. And women in this country, we have a large majority of them who are breadwinners in the family. And as Dr. Davis-Simmons would have shared, obesity being a chronic relapsing condition, comes with it, brings along with it many, many other health issues.
All right. So with that will be our last question for this evening. Again, I want to thank Dr. Martin, Dr. Davis-Simmons, as well as Dr. Ranga for taking part in our distinguished lecture series this evening. We encourage, for those of you who may still have questions, we encourage you to reach out to our weight loss solutions team at Centerville Medical Center. The phone number is 302-3256. And you're also able to find them on our website at clinics.doctorshosp.com. You can also book an appointment there. We thank you, our audience, for being with us this evening. I hope that you got a lot of good information out of this. And again, if you are interested in finding out more, you can reach out at 302-3256. Thank you, and we'll see you next month back here for the Doctor's Hospital Distinguished Lecture Series.